the National Breast Cancer Foundation, who've been long-term funders of our National Research Project, which involves family history of breast cancer. And I'd also like to pay respect to our elders of this country and the land where we meet today. Now, how do I... Oh, this is what I move forward. Hang on, sorry. Right, so Kconfab was established in 1997, and basically we're a biospecimen and a data biobank or cohort study to facilitate national research into the genetic aspects of breast and ovarian cancer. Certainly the breast cancer genes we deal with, BRCA1 and 2, are probably the best known to the people in the audience today. And I never want to alarm anyone because only 10% of families fall into that high-risk category, but they do carry a terrible burden because 50% of all females are diagnosed with breast cancer. Because of the genetic faults they carry, they're also prone to ovarian cancer. And we know that the men also now carry, if they carry a genetic fault in the BRCA2 gene, develop a very, very aggressive form of prostate cancer. So Kconfab is very multidisciplinary. We have community representatives, surgeons, clinical geneticists, genetic counsellors, epidemiologists, scientists, all working together in a concerted effort Australia-wide. The operations are that we have 10 research nurses based in all the family cancer clinics in Australia. Most of the family cancer clinics are attached to the public hospitals, and the good news is they also, as well as doing city clinics, do regional and remote clinics as well. We recruit these high-risk breast ovarian cancer families, and we recruit all males and females over the age of 18. Blood and tissue is collected daily and flown into our laboratory here at Peter Mac in Melbourne, where our database is also located. I'm not going to go into the specific details about our recruitment criteria, but it was formed after a very stringent scientific review. But basically, to do genetic research, you need large families where there's multiple people with breast and ovarian cancer and multiple family members unaffected by cancers. As I've already said, we recruit people, first and second degree relatives, over the age of 18. And to come into our study, you can fit into 4 criteria. You can be a large family where there's multiple cases of breast cancer but no genetic fault found. You can be a family where we have found a genetic fault in BRCA1 or 2. A family, and thankfully these are rare, but other breast cancer genes known as P53, ATM, PTEN or PELB2. And our 4th criteria is women who belong to a high-risk breast cancer family who don't want to involve other family members, which is fine, but they're happy to donate a fresh tumour to us because this is really important for our research use. So 99% of our families are recruited through our family cancer clinics. This has been an optimal strategy for us since 1997 because it's given us a steady supply of high-risk breast cancer families. But it also means as researchers, if any of our family members have questions or concerns, we can hand them back to the health professionals in the clinic for appropriate advice. Members of each family are asked if they'd like to be involved in our study. Those that are agreeing to do so are referred across to our Kconfab nurse. We gain consent from that participant and then they help us to recruit the other family members. Everyone completes an epidemiological and dietary questionnaire. The consent form's also very clear that they're providing a blood sample so that we in the research setting at Kconfab can do extensive genetic testing and that also their blood DNA will be used to facilitate other research projects. And of course, I'll get onto this later, but many of our participants do obviously have, unfortunately, tumours removed at surgery, but many of our women also have prophylactic mastectomy to prevent cancer. So that tissue is also collected by us that's in access to diagnostic purposes. With consent, we also put the family structure onto a database, and through each individual, we can link the pathology, all treatments, our genomic mutation results. We have very extensive follow-up, and just as importantly, the database can also track when blood tissue comes in, when data comes in, where it's stored, and just as importantly, who we've given that material to facilitate research. Any researchers in the world can apply to Kconfab to access our biospecimen and data resource. We have two types of projects, a pilot project that is small in size and are normally approved for 12 to 18 months, or else researchers can come to us and have a full project. They're approved for 3 years. Amendments can be made at any stage and can be extended. In fact, the majority of our research projects have been running for 10 years now. The mean time from a project being submitted to us to actually gaining approval is approximately 3 months. So we try and fast track this approval system as quickly as we can. We have obligations of the researcher, but I'm not going to run through those today. I just want to mention too, due to funding situation in the last couple of years, Kconfab also acts now as purely a service provider. We have 12 other similar groups in Australia in other cancer streams who come and use our infrastructure and genetic platform, if you like. They use our nurses Australia-wide to collect blood, tissue and data. Sometimes they've modified our database at a greatly reduced cost. They use our laboratory to process biospecimens and use our QA/QC service. Transport courier we've used for 15 years. They give us a very cheap price, so people are happy to log into that with us. And they can also use our mutation testing facility, which is very quick, cheap, and much quicker than a clinical service. Basically, it depends on what they're doing, but we just charge this at an hourly rate with no profit. I think the most important thing here is that Kconfab has no involvement with the governance of these external groups, and it's certainly much cheaper to graft into our infrastructure than set up their own scheme. Now, getting back to Kconfab, so what are the benefits to a participant or a family to be in a Kconfab research study? Certainly we do a lot more thorough genetic testing because we're research than a clinical service. We've fed 3,500 mutation test results back to our families and the individuals in the families and to the family cancer clinics looking after these families. We provide information about the family-specific mutation into the extended family, and by that I mean often only 1 or 2 people in a family have been to a family cancer clinic, but we recruit the whole family, on average 10 people per family. So we have a mechanism for getting these research test results back to our families. We're often a first port of call for advice as we have ongoing close contact with families and breast cancer support groups. And I think this next point's really important. All research, just not the research we're doing, can be very passive and very conditioning to people about, their disease. And we provide a very important educational role before people sometimes will attend a clinical service. By this I mean we've researched this. Sometimes when we let a family know that there is a genetic fault in their family, it can take 5 years for people to actually front up to a clinic and have their own predictive testing done. It takes that time sometimes for people to see that there's more pros than against in having your personal, genetic testing done. We certainly provide personal risk assessment for gene carriers and non-carriers in a family. This is important because if you don't carry the genetic fault that's been found in your family, you're at no greater risk of developing cancer in your lifetime than, say, I am with no family history of cancer. We have many opportunities to extend in further research about familial cancer. Kconfab's been very good at doing that. I'm going to get onto this later, and it's probably my most important point of my talk today. We've provided a lot of information and access to our participants about the new gene-targeted clinical trials that are in the clinic now. So, our progress to date. As of August 2014, we've completed collection on 1,600 high-risk breast cancer families in Australia and New Zealand. On average, we have 10 bloods per family, and on average, we have 4 breast cancers verified per family. We have pathology reports on 8,500 breast cancers, and we've completed epidemiological questionnaires on 20,000 people. Now, one of the questions we ask on the EPI questionnaire is, what is your ethnic background? And we ask this of both the maternal and the paternal side. We have 75 participants, 48 females and 27 males, from 42 families who've nominated that they're Aboriginal, Torres Strait, Maori, White Caucasian, Northern European ethnicity. I'm not going to go into a lot of detail about this today. We can drill in further, but 15% of these participants have attended university, 16% vocational training, 53% secondary education and 12% primary school education, and 24% of our females have been diagnosed with breast and ovarian cancer. None of the males have been diagnosed with male breast cancer, but a few have had other associated BRCA 1 or 2 cancers like pancreatic and prostate cancer. Now, this is where I think it gets quite interesting. So when we find a genetic fault in our research study, we send a letter to everyone in the family who's consented, who has indicated on the consent form they'd like to know if we find a genetic fault in the research study. So Kconfab has sent a mutation notification letter to those that indicated on their Kconfab consent form about a clinically significant mutation being found in their family. So there are, out of the 75 Aboriginal Torres Strait participants, there are 20 participants from 14 families who indicated yes on their consent form. 13 females and 7 males, and I know the numbers are very small, so I don't want the mathematicians jumping on me today. I know we can't get a p-value, but this is very interesting. 13 out of the 13 females and 3 out of the 7 males have attended a family cancer clinic for genetic testing. I reiterate, the numbers are very low, but that's 80% of the Aboriginal Torres Strait Islanders have been to a family cancer clinic versus 38% in our whole cohort. We know that 77% of these women have had a prophylactic mastectomy. We know that this reduces their cancer rate by 80%, and 48% have had a prophylactic oophorectomy. I'm not going to go through the rest of this because, in conclusion, I've got a very important message here. We've already talked about the cultural, the religious, family attitudes to accessing any clinical service. It's the same in genetic testing. But can I also say, in a practical sense, sometimes the women just say to us, I know I should have been to a clinic. You know, these are women between the ages of, say, 30 or 40. Look, I'm juggling work, I'm juggling relationships, I'm juggling children. When am I going to get there? So genetic testing uptake isn't taken up, immediately by everyone. But without doubt, this is my most important point today. The benefits for improved health outcomes and access to new prevention strategies and treatments are far outweighing the disadvantages in the current health treatment climate. Personal risk assessment for cancer prevention, we've already heard about some of it today. Many of our young women now are having MRIs instead of mammogram annually. We know that they're safer because they're not ionising radiation. There could be a bad effect with a BRCA1 mutation and mammograms, and an MRI is 100 times safer. 100 times more sensitive than a mammogram. But of course, we're now in the personalised genomic medicine where N equals one person, which isn't quite true because we do have, multiple people with the same genetic fault. But the reality is, in the clinics now throughout Australia, we're testing people with breast cancer, their blood DNA and their tumour DNA to see what genetic faults they carry so that we can put them on these new targeted therapies. These targeted therapies are wonderful because they have very few side effects. We don't have hair loss, we don't have nausea. They're extremely well tolerated, and thankfully the days are just about going, I think, with the new personalised medicine where we treat 60,000 women with the one drug for breast cancer, but we know in our hearts that perhaps only 10% are ever going to respond to that therapy. Looking at future research, our resource is open. If any researchers here today would like to go back to these Aboriginal men and women that we've already consented to see what were the enablers or also some of the barriers in getting genetic testing, we certainly could recruit more participants if any researchers here would like to work with increased numbers. And of course, at our fingertips, we have whole genome exome sequencing to look for new breast cancer genes in the whole Australian community, but also the Aboriginal and Torres Strait Islanders, if anyone would like it. Good, thank you very much.